Alright, today we're going over cellulitis. So, once again for cellulitis and then the ID lectures, this is just for educational purposes and it's based on MixApp up to date as well as our local antibiogram, so it might not be relevant to you for where you practice with the specific antibiotics. And also, this is made in 2024, which also could change in the future as well. So, let's go through cellulitis as erysipelas, pathogenesis, microbiology, diagnosis, differential, and treatment. So for the pathogenesis and microbiology, what's really occurring here is, or what really puts you at risk for cellulitis is really any introduction of bacteria into the skin, getting through that epidermal layer, into that dermal layer as well. So, this can put you at a couple of different things, anything like trauma, cuts, abrasions can decrease that skin layer to increase risk of cellulitis. 2 would be any sort of inflammation of the skin, so a lot of your primary dermatological disorders. The big one you see a lot is eczema, with the inflammation of the skin, subsequently causing breakdown of the skin, cracks, which can introduce bacteria as well. 3 is going to be any edema, so especially lymphedema gives you a localized immunosuppression, which puts you at risk of developing an infection by being able to immune system to not eradicate any bacteria. And then lastly, you're looking at any immunosuppression in general can put you at risk for cellulitis. So what are the main bacteria that cause cellulitis, that cause inflammation and erysipelas, inflammation of the dermis of the skin, and subsequent infection of that area? Well, the first one you want to think about is going to be strep, and the second one is staph. So for strep, this usually occurs, it can have really 2 different presentations. So one presentation is going to be that infection of that really superficial layer of the skin right here. So you can see that there's inflammation here in the upper dermis from here to here. This superficial infection is going to cause some of the manifestations that you see on physical exam, right? So it's superficial, so it's going to be beet red, as the inflammation is so much closer to the surface of the skin. Superficial and spreading means that it pretty well demarcated, doesn't go to the deeper layers of the skin, so you can really see exactly where that infection stops. And then lastly, it's going to be a bit more red as well, secondary to that superficial inflammation. The other thing that you can get with strep infections is a non-purulent cellulitis too. So this is kind of what you see here with that non-purulent cellulitis. There is involvement of deeper layers of the skin here with inflammation, subsequent infection in the lower dermis. So syphilis. Here you see a picture of this, and we call this non-purulent cellulitis. So really, strep can cause erysipelas and really cause non-purulent cellulitis. It does not commonly cause purulence. When you do think of the purulence, which here you see an abscess, you really think of staph, and that can come in 2 major flavors, being MSSA as well as MRSA. And this is what you're going to see on exam for staph with basically a purulent infection. May have abscess, may have purulence, being overlying eczema, or may have abscess formation as well. If there is an abscess, in these cases, one, treatment's going to be a little bit different. You're going to have to do an IND. And also, a lot of times, if you can't diagnose by physical exam, you might need to diagnose with a superficial ultrasound, and in certain cases, culturing the purulent fluid from drainage from an abscess, especially if it's the one they have to intervene on, can be very, very helpful to subsequently delineate antibiotic treatment. Other things to think about when you think about cellulitis is what is your differential? Now, a lot of things look like cellulitis, and the diagnosis of cellulitis is mainly clinical, which means it can be sometimes prone to errors. So differential diagnosis, always be thinking about deeper infections, right? Do the patient have pain outside of the area of cellulitis, especially extreme pain? Do they have crepitus? Do they have bull-eye formation? In those cases, you should be thinking about a neck vash. You might need a CT scan, a surgical consult. Does it go deeper? Is it near chronic wound? Do you need to think about the patient having osteomyelitis in consideration of X-ray? And if that's negative, then still high suspicion in MRI. Nextly, other cause of inflammation can look like cellulitis. So one of the most common, things on the differential that is mistaken for cellulitis is stasis dermatitis. So someone with venous insufficiency in the legs getting stasis dermatitis and subsequently getting diagnosed with cellulitis. So things that you might see that might clue you in that stasis dermatitis is one, the patient doesn't have signs and symptoms of inflammation, no leukocytosis, no fevers, no severe pain in that area. They may have things like varicose veins, looks like hemosiderin deposition, signs of stasis as well. That kind of clue you in for stasis dermatitis, which the treatment is different, and it is treated a ton as cellulitis, which puts the patients at risk for long-term antimicrobial resistance. So that's one. There's other rare causes like vasculitis, eczema, even erythema nodosum, but those are probably one of the more common causes of a mistaken diagnosis for cellulitis. And lastly, another thing that can cause redness, swelling of the leg is a VTE. So consideration of a lower extremity ultrasounds in cases where you think that a VTE could be on the differential diagnosis. Lastly, gets to treatment. So how do we treat these patients? Now, it kind of depends. So I think we'll start off with the sickest patients. Severe sepsis, immune compromise, you do want to cover MRSA, MSSA, and strep. For these patients, you're really going to use a broad spectrum gram-positive agent, like vancomycin, daptomycin as well can be used, and you are going to need a antibiotic that covers most of your gram-negatives as well as Pseudomonas. At our hospital, we use cefepime. Other hospitals, you might be able to use something like piperacillin, tazobactam, carbapenems, but those would be a little bit too broad spectrum. That isn't totally required in these situations. So that's going to be your IV treatment. Any patient really that's coming to the hospital and has risk for MRSA, you're going to do IV vancomycin. But if they have severe sepsis, meaning they have end organ dysfunction, or they have pretty severe immune compromise, you are going to cover MRSA, MSSA, strep, gram-negative bacilli, and Pseudomonas, and your typical go-to is going to be like vancomycin plus cefepime. Now let's go through oral. I'm going to go through your outpatient or subsequent narrowing of the antibiotics above if you're not able to narrow based on cultures. So for non-purulent without MRSA risk factors, those patients by and large, as it's going to be non-purulent, is going to be secondary to strep. Now you are still going to pick antibiotics that cover MSSA just in case. So your typical go-tos for this one, at least by antibiogram here, is going to be cephalexin, or you can also do decloxacillin as well for your oral antibiotics. Next, now if someone comes into the hospital and they're not severely septic, they don't have immune compromised, they have a non-purulent cellulitis, in our hospital we're able to use cefazolin for that, which is the IV equivalent of cephalexin. Now let's go through purulent. I think that is probably kind of the antithesis of non-purulent, so we'll go through that one. So for purulent infections, you are required to treat MRSA. You are also required to treat MSSA as well. So your typical go-to, at least from our hospital, because clindamycin doesn't work, is going to be Bactrim. Now Bactrim also does get a little bit of strep on there as well, but I won't include it in this diagram currently, or you can use doxycycline. So Bactrim does, maybe I'll extend this for Bactrim, get strep, but really strep not required. If it's purulent, you think it's staph, and you really do need to cover MRSA, MSA, and strep. Now, one of the harder ones is that what do you have a non-purulent infection with MRSA risk factors? In these cases, you really are required to cover MRSA, MSSA, and strep. There's two different ways you can do it. One, you can do Bactrim alone. I used to think that because Bactrim doesn't have in vitro susceptibility for strep pyogenes, that doesn't have in vivo, but it's been shown that in vivo susceptibility for strep pyogenes to Bactrim is quite high. So Bactrim can be done by itself. The other thing you could, so Bactrim or, add on or here, you can do Doxy as well. Now Doxy only covers MRSA, an MSSA. So if you do doxy, you had to add on amoxicillin. So those are your typical go-tos for oral treatment of non-purulent or oral step-down. Treatment or oral step-down for non-purulent with MRSA risk factors is Bactrim alone to cover MRSA, MSA, strep, or doing doxy and amoxicillin. Lastly, and this one does get a little bit difficult, but when do we end up covering gram-negatives and anaerobic coverage? There's different lectures on this, but the cases where you do consider this is one is going to be the location. So where do your gram-negatives live? Really in your GI tract, somewhat in your mouth, mostly GI tract. So location is if it's around any mucous membranes. Chronic wounds may have, say, like a decubitus ulcer or diabetic foot ulcer, increase your risk for a polymicrobial infection. So near chronic wounds would be an indication to cover gram-negative and anaerobes. And then lastly, the time they're going to cover gram-negative and anaerobes is going to be any necrotic skin near it. Now, if you do see necrotic skin, definitely increases your suspicion for necrotizing fasciitis, but if you do have a cellulitis near some dead skin, you do need to think about gram-negative anaerobic coverage. Lastly is going to be exposures. So a lot of times with exposures, let's say to a bite, bites, mouths, human mouths, dog mouths, cat mouths really have polymicrobial infection in there, so you may need to add gram-negative coverage in those cases, and then as well as anaerobes, and then lastly water. So especially punctures in the foot that goes through the shoe, you even have to think about covering Pseudomonas in these cases as well. So it's another indication for really broadening your coverage. Now there's different ways that you can broaden the coverage here. If you have the patient with severe sepsis, and let's say you're on vancomycin and cefepime, just adding on some metronidazole would be adequate. If you use, let's say your hospital uses Zosyn, that's good, and Zosyn covers anaerobes while cefepime doesn't. Cephalexin and tacloxacillin don't cover it as well as you would like. So one thing you could potentially do in this situation, if you're doing oral coverage, is actually just do Augmentin, which is amoxiclav, is one way you could do it instead of using cephalexin or tacloxacillin. Or in the cases of non-purulent with MRSA risk factors, you're already using amoxicillin just to get that gram-negative and anaerobic coverage. Here, just add on clavulanate. Now this may be a little bit simplified, but and obviously whenever you have cultures, base your antimicrobial decision based on that long term. But in a pinch, this is helpful for just a general guideline for empiric management based on our Cooper guidelines. So that's all I have. Thank you.